So I'm Adrianna Hopkins. I'm going to start by saying thank you all for joining us tonight for this awesome conversation we're going to have. This is on behalf of the White Dress Project, Dialogue with Doctors. Tonight's topic is our secret burdened, heavy menstrual bleeding. What is normal and what is not normal? So thank you all again for being here tonight. Nikki, our engineer behind the scenes, put up a brief description of how this chat will go in the Zoom group chat. So if you go to the bottom of your Zoom and you hit that chat button on the right side of your screen, you'll see, the request to mute yourself when you're not talking so that we can hear the doctor speak uninterrupted. You can submit any questions that you have in the chat. Again, they're on the right side of your screen. You can direct them to me. You can direct them to the doctor, so the patient advocate, if you would like, or if you type it to everyone, we can all see it. This is a safe space, so don't be embarrassed or ashamed or anything. We've all had our own experiences with fibroids and heavy bleeding, so no shame here. This is a judgment-free zone. And lastly, you can see our social media handles there as well in the chat room, in the chat box. If you want to follow the doctors, the patient advocate, or myself on social media. So with that, let's go ahead and get started. There's a lot of great people on the panel here tonight that I want to introduce you to. Let's start first with our patient advocate, Devin Arielle Prater. Now, she is a licensed federal criminal defense attorney who practices in Maryland. That's my neck of the woods. She's also a soror who graduated from Howard University, Alpha Kappa Alpha Sorority Incorporated, and she got her law degrees from Georgetown University Law Center. Now, Devin advocates on behalf of marginalized populations in the courtroom for her entire legal career. And then when she had her own experience with fibroids, she learned the importance of advocating for women in the doctor's office as well. So Devin, great to have you here. Thank you so much for your time. Look forward to having you share your expertise tonight. Also, we have Dr. Klarra King. She is a Chicago-based OBGYN. Now, she cares for women throughout their lives, but really has a passion for working with teen moms. She's a sought-after speaker. She's created the premier destination for style, wellness, and modern motherhood on her website, drkiaraking.com. That's Klarra, Kiarra, king.com. She's also traveled to speak on critical women's health topics like breast cancer and self-advocacy. She's also written on key subjects, including cervical cancer and postpartum depression. So Dr. King, thank you so much for joining us tonight as well. And last, but certainly not least, we have Dr. Somi Javed, like First Aid. She is an OBGYN based in Cincinnati. There, she opened up her own clinic, one that really caters to women and those who have, and one that takes health insurance. Now, her mission here is to close the gender gap and to provide all women with access to exceptional health care. She has a basis in sexual health and gynecology. So Dr. Javed, thank you for being here tonight as well.
Thank you.
Yes, okay, so again, the topic of the night is menstrual bleeding. This is something that is one of these really taboo subjects. We don't talk about it enough with each other, so we don't really, at least I find, women don't have a basis for what is normal. I can share part of my experience, and people who work with the White Dress Project know, but I had 10 fibroids removed, and I felt as though I always had what was considered a heavy period. I didn't necessarily realize there was anything wrong with my heavy period. Like, it didn't trigger anything for me to go to the doctor and say, hey, so I think maybe my period's a little heavy. But then after the fibroids were removed, period's not so heavy anymore. I feel like had someone told me about heavy periods and normal periods and light periods and regular periods, and this was discussed, maybe I would have had a clue. So Dr. Javed, I just want to start with you and talk about what is normal.
Yeah, so I don't like that word in my office, normal, because I don't want people to feel like they're abnormal, right? So we use words like typical or what you can expect. And so I tell people really, periods that last 7 days or less, you shouldn't be in pain all the time with your cycle. You shouldn't be bleeding more than a pad an hour. PMS symptoms can be typical, but it doesn't mean that you have to struggle with them. I tell people fevers or nausea or vomiting or problems with constipation or, infertility, which we define as 12 consecutive months of, having intercourse and it's unprotected and you don't get pregnant. Abdominal distension, if people are like, oh, my belly's getting bigger, back pain, leg pain, bleeding longer than 7 days, bleeding more than once a month, or the opposite, going more than 3 months without a cycle or greater than 42 days if people are skipping periods. So those are all flags that someone should call their doctor, or maybe their bleeding pattern isn't typical or the way that it should be.
So Dr. King, I see you nodding your head here in agreement with Dr. Javaid. Do you find when you're seeing your patients that this is a topic that women raise, or do you really have to dig?
No, I find that a lot of times women are coming with this issue. And I will say sometimes women are coming with the issue, but also we do have to investigate with some women. You start asking questions and they're like, oh, well, I just thought that was normal. Because like you said, if they don't have anyone to kind of, again, normal, I totally agree with Dr. Javaid, because it's, it's what's normal for that particular person, but it may not be normal for everyone else. But I've definitely had to dig for some patients. I've had patients where I'll say, we generally will ask about a woman's period when they come in. As a gynecologist, it's just one of our questions. We ask them when their period started. We ask them how long their period lasts. We ask them how often they get their periods. And then any other, concerning symptoms or any symptoms that they have surrounding it. And sometimes patients will say, oh yeah, my periods last for like 10 days. And yeah, I guess they're kind of heavy. And they kind of downplay what, once we kind of are doing our investigation, we're kind of like, this is a little bit not so typical, as Dr. Javaid said. And you will find, I found that some women have, for example, been severely anemic and they're walking around and their bodies have compensated for their anemia. Anemia, if you're not aware, is when your red blood cell count is low. So because women lose blood every month with their periods, you may be a little bit anemic around that time, but generally your body will be able to make up for it and will return to a blood count or hemoglobin that's within a normal range. Where I've had patients come in and say a normal is, let's say, around 12. And I've had patients come in at 7, 6, 5, and they're sitting there as if nothing's wrong. But then when you start asking, you may have received their lab work or something beforehand, so you have that information. And when you're asking questions, they're like, oh, well, yeah, my periods have always lasted 2 weeks. Or, yeah, I usually get these really, really big clots, 3 days in a row, or, what have you. And so sometimes when we dig a little bit more, that information does come out. But I find that also a lot of women are coming in and they're self-reporting that they're having heavy periods.
Now, Dr. King, you do work with a lot of young mothers, teen moms. In terms of the education out there, how would you say, what would you say that teen moms, the younger generation, what do they or don't they know about women's health, sexual health, menstrual periods, fibroids, etc.?
I think it's quite variable. I think there is a lot of work to be done in terms of educating younger women. I participated in a campaign just last year that talked about tampon use and the taboo in the African American community specifically. And I think there's just a lot of work to be done around our bodies, being comfortable with our bodies, being educated about our bodies, what we can and can't do with our bodies. And I think that's kind of across the board, whether we're talking about period health, whether we're talking about menstrual hygiene product use, and just general health in general. I think there's kind of a lack of information out there. And unfortunately, when there's a lack, people will go and search for their own information, and they may not always come across high quality, reliable information. So I think there's some work to be done.
I've always said Dr. Google is the devil.
Yeah.
Yeah.
Sex education is huge, for sure. Agreed. And just personally, I have a teenage daughter. She brought home her high school little pamphlet, and I literally marked it all up
Oh
because
God.
almost everything was wrong. And then of course I signed, I put her mother, and then I said MD OBGYN, so they wouldn't think I was crazy. But I want, women to be empowered. I want young girls to learn about their anatomy. And I'm sure you have this too. I have so many women come in, they don't know what their vulva is or their labia is or their uterus, or they'll come in and they'll have had surgery and they're like, well, I don't know what I have left. And I'm like, did you not ask your surgeon what they took out? No, he or she just did it. And I was like, well, we need to know what you have left. So, it's always amazing to me. And I feel like that women, young girls, we don't have a safe place to ask the questions we want to. And so oftentimes, yes, women are seeking it out in the wrong places, and left with a lot of misinformation. And I think that's why we live with our symptoms so long, is we just don't know. Or we're so busy as caretakers, taking care of our children or our spouses or our sisters or mothers or brothers, that we sometimes, I think that's how your women of hemoglobins of 5 are still walking around, because they're taking care of everybody else and they're not taking care of themselves. And so that's, my passion is reminding women that if we don't take care of ourselves, we can't take care of everybody else. At some point, your patient is not going to be able to walk around, right, without having symptoms, or to be able to continue her activities of daily living. So I think education is huge.
Totally agree.
I totally agree. And I find from when I speak with young women, especially, the education is inadequate. And this might just be stereotypical, but I feel like oftentimes the education materials, that pamphlet you got, was put together by a man who knows nothing about a uterus or ovaries or fallopian tubes or getting a period. So Devin, I want to bring you into the conversation right now, because we are talking about patient advocacy. And when you call yourself a self-advocate, when did that start? How did you feel empowered? And how are you advocating for other women?
Yes. So I think for me, what really placed me on this journey was realizing after my fibroid removal that so many other women had gone through the exact same thing that I went through. And I guess just to kind of, backtrack on that, I first found out that I had fibroids after kind of having a bleeding episode in federal court. And so it's literally my very first day in federal court. I'm assigned to be there with another attorney. And the way court goes, right, the judge walks in, all rise, you stand up, you sit down, they call your case, you stand up, you sit down, they, call your client, you stand up, you sit down. And literally in the middle of all of this standing up, sitting down, standing up, sitting down, standing up, sitting down, I'm like, oh my goodness, I have to go to the restroom. And it's a moment where I don't know how to say it to the judge. I don't know how to say it to my co-counsel. And at that time, right, I should be able to. This is no different than, right, I'm having any other type of an emergency. I have to sneeze. I have to go, vomit or something like that. Those would be normal things to say in court. But on the record, of course, I'm embarrassed to, even bring up the issue and have a judge be like, well, what do you mean you have to go to the restroom? Didn't you just go? And so for the longest time, I kind of suffered in silence because I thought that there was something, I wouldn't even say wrong with me. I just thought that my normal was different than other people's normal, and that it was just something that I had to go through. And I think that so many women, whether it's physical issues or relationship issues, right? We hold this shame that, well, maybe if I tell somebody about it, they'll look at me differently, or maybe they'll think that I'm less of a woman, or I'm not as strong, or I'll freak them out by, oversharing too many details, because who really wants to pull, someone else to the side and be like, hey, I think I'm bleeding too much. That's just not part of our regular conversation. And I really recognize that I could have avoided so much heartache and stress and time on WebMD, time, speaking to people who did not come from positions of education or authority, because I was just kind of hiding in the crevices of the interwebs, not, knowing about the White Dress Project at that time, or knowing about all of these amazing places to get this information. And it wasn't until after my surgery that women, friends, colleagues were literally calling me like, oh my gosh, I didn't know that you were going through that. I went through something similar. And I'm like, well, I didn't know that you went through that. Or they're telling me about their cousin, or they're telling me, about women who I perceive to be, strong, powerful women who are juggling multiple things. And suddenly that was when I realized, right, like, this is something that definitely needs to be brought to the forefront. Not just in terms of making women feel more comfortable in sharing, in these types of spaces, but also with our close networks of friends, just checking on each other when, we're having casual conversation and someone's like, oh my gosh, like, Aunt Flo is here and it's, kicking my ass, maybe sometimes asking, what is that like for you? In a way that is obviously respectful of the friendship and the relationship. But I think that sometimes we're just not allowing ourselves to be open about these things. And it's scary because when men get in groups, right, the things that we kind of think are taboo, that are at the top of the research list, right, like in terms of Viagra and all of their, sexual health issues, it's regular locker room banter for them. It's normal. And no one thinks of them as less of a man or someone who's less capable to do their job or to tend to their responsibilities. And so it just really became important to me to not have other women go through what I went through. And I also think Dr. King and Dr. Javed, I applaud you, because I wish I had doctors who were as approachable as you were. And so that's the other piece that I'm learning. Part of the advocacy is not just making sure that you're getting the information and you're asking the questions, but making sure that you're partnered with someone as part of your care team who really understands what fibroids are, want to understand what fibroids are, and if they don't, will refer you to someone or say, that's not my area of expertise. Maybe you want to go talk to this person. Because I think I came across so many different doctors who sometimes it's like that for women, these are things women go through, and you kind of leave feeling like, okay, well, maybe I'm just being dramatic. And that's just it's not the case, and it shouldn't be the case.
Absolutely. I totally agree. Go ahead, Dr. King.
I just want to say something on that. And I tell patients, I've actually written about that a couple of times in terms of how to advocate for yourself, because I think a lot of times people don't even understand that they can be well educated. They just don't understand that they have the capacity to advocate for themselves in a medical space. A lot of people are going to the doctor's office and they're like, well, I'm going to see the doctor, this authority figure over my health. They're telling me what's right. Do I have the right to question them, about my health? And I've had patients come and they'll be like, I'm really sorry, I have this question. And I look at them like they have two heads. Like, what do you mean you're sorry? Like, you're here to discuss your health. Like, this is the place that you ask questions. And I tell patients all the time, if you're going to see someone and they have a problem answering questions for you, now I'm not saying you can go and have your list of 500 questions. Like, that just may not happen. But if you have one or two questions and they're bothered, annoyed, they don't have time to answer, that's a huge problem. That is a red flag. Go find another doctor. And I say that as a physician. And unfortunately in marginalized communities, that happens all too often. And then, we Black and brown people are sitting out there not having optimal health care because, well, we were kind of shushed in the office or told, oh, it's no big deal, or you're fine, or what have you. Like, we have to be able to advocate for ourselves. You have to know it's okay to ask questions. You have to know it's okay for you to go find a second opinion. And again, I don't say that just to encourage people to doctor hop at all and just go hopping from one doctor's office to another, but you're going to know whether, you kind of hit it off with that doctor or not. And not that they have to come in and give you roses and candy and all that kind of stuff, but you're going to know within, the first few minutes if you feel like there's a connection, if you feel like that person is warm and is, hearing you out. And again, the other caveat that I have to that is, obviously physicians are busy people. So are we going to be able to spend 30, 40 minutes, an hour with you every single time? Absolutely not. But I think everyone, whatever your career is, has the capacity to treat people like human beings, even in 2 minutes, in 1 minute. You know what I mean? So it doesn't take a long time for you to figure out if somebody's a good person. Obviously, doctors have good days and bad days, but I don't know if, I feel like you can kind of get a feel for that and be able to determine if, if you feel like you're in a good relationship with that physician, if you feel like that person is hearing you out, things like that. So I think that's a great point that you brought up about advocating for yourself. I'm like that's a huge passion of mine.
No, I totally agree with you. And I know, I've been to doctors that don't have the best bedside manner at all. And it's kind of like, how many more questions are you going to ask? And I've got to, see somebody else. And it's like, if you don't have time, I got to move on. Plus you have to consider, like, you might be the surgeon cutting open my body. So I'm going to ask you all the questions I have time for. And then I have some really great doctors. I take my daughter to a doctor and he goes through everything and explains everything. Then he says, what questions do you have for me? Let's go. Mm-hmm. And, he expects me to ask him things. And so that's always the doctor that I kind of prefer, because it lets me know that you care that I'm a person and that I'll have to live with this when I leave your office. Okay, I want to dive into just some of the quick facts about typical periods, because we're getting some questions right now about how long periods should be, if there should be pain involved with periods. So I want to start by asking Dr. King and Dr. Javed, talk about first, how much should you be bleeding? I've heard, maybe 3 teaspoons or a tablespoon or whatever this magical number is that I never experienced in life. I was bleeding buckets, I feel like. But what would be alarming, or what would be something that you say, okay, time to go to the doctor and have this checked out?
So Dr. King and I, we are part of American College of Obstetrics and Gynecology, and they used to have all these definitions of how many milliliters or teaspoons. And I think ACOG has generally jumped to patient perception, which I love. So if a woman or a teenager feels like her bleeding is heavy, then it warrants being investigated, and it's abnormal. If we have to look at numbers, because some people really like to measure that way. My 11-year-old asked me, for a period app. And so I gave her one so she could keep track of the days she was bleeding and the interval between cycles. You don't want to bleed more frequently than every 21 days. And we count from first day to first day, not from end to start. Typically anywhere from 21 to 42, or there's different books that will tell you different things. For me, I tell people, if you're bleeding more than a pad an hour, or if your pain or cramping is not resolving with over-the-counter Tylenol, heating pad, Motrin, Advil, then those are all signs and symptoms that something's wrong. Very, very large clots, not normal. Some women can pass clots, when you lay down and you sleep, obviously the blood is going to clot. You can wake up in the morning and you can pass clots, but very large clots, feeling dizzy, obviously, like Dr. King referred to, being anemic, like those numbers she threw out. None of that is, normal or typical. And so those are all signs that it needs to be addressed, especially the pain. So those are things that definitely warrant a call to an OBGYN.
Now we do have a question here. Is it normal to have vaginal pain to the point that it's hard to sit during your period?
Yeah, I would say no. I mean, if it happened one time and it's like a rare occurrence, it happens one time and you sit and then it kind of goes away, or you reposition yourself and you're fine. But if you're having significant vaginal pain, and like Dr. Gervais said, you take some ibuprofen or Motrin or any kind of non-steroidal, and that pain is not relieved, that may be, an indicator that there's something else going on. You could have a fibroid on your cervix, you know what I mean, that's causing pressure or pain in the vaginal space. But I would definitely get it checked out. And the one thing I think that's interesting is that some of the symptoms that have been described, having painful periods, we call it dysmenorrhea in medicine, or cramping. It's not uncommon to have cramping with your periods, but if it is significantly affecting your quality of life, that's where the issue lies. If you have a few mild cramps and you don't even bother taking, an ibuprofen for it the first 1 or 2 days of your periods, and you can kind of get by, it's probably not anything we need to do any major investigation for. If I have a young girl or even an older woman who's working or going to school and they are missing school for the first 1 or 2 days of their cycles, that's not normal. And that's something that needs to be evaluated. And when those people come in the office, we're obviously asking, okay, what are you doing? If you're at home for 2 days and you haven't even tried to take any ibuprofen, you just want to be out of school, we gotta investigate that. But if you're laying in bed round the clock, heating pads, your parent or caregiver is bringing you round the clock medication is just not helping, that's something that needs to be investigated. And same for an older woman who's maybe has a career, who's working. If it's limiting your normal daily activities, those are things we need to check out.
And when Dr. King says checking out, it's history, like talking to Dr. King and I or your OBGYN, it's a physical exam. There's a lot of things we can pick up. So if we place the speculum, and there's a fibroid on the cervix, we can sometimes see that coming down. And then an ultrasound, right, which is imaging of the uterus and the ovaries. And I know we're talking a lot about fibroids, and that's so important because millions and millions of women are affected and go undiagnosed. But there's also things like polyps and ovarian cysts and tumors and cancers and infections that can also cause very heavy or abnormal bleeding. That, that history, physical, and then that blood work that Dr. King was referring to about those lab tests, that's how we can tell if someone's anemic, and getting that ultrasound imaging. And that's all something that a patient doesn't have to go to the hospital. It can be done in most OBGYN offices.
Mm-hmm. So in terms of if a patient says, I have all of these things and I would really like to get an ultrasound or, do a deeper dive, is that something that would be, reasonable for them to ask?
Absolutely. Absolutely. I mean, if someone is coming to me with, again, not pelvic pain for 1 day, but if they're
Right.
I've had the past 3 cycles, or since I started my periods 10 years ago, I've had painful cycles, or I think my periods are kind of heavy, I'm not really sure. And like Dr. Gervais said, we take more history, ask more questions. We ask about surgeries they've had. We've asked about their obstetric history. Did they have trouble getting pregnant? Those all kind of help us determine, okay, this patient had infertility for 2 years and had to do IVF. Maybe there's some endometriosis that we don't know about. And so asking those questions will then prompt us on what type of workup we need to do. If someone's coming with heavy bleeding, they're automatically going to get a blood count so we can see if there's anemic or any other anemia or any other type of blood disorder. We're going to check their thyroid to see. Sometimes thyroid dysfunction can cause really heavy periods, or sometimes even absence of periods. And depending on the rest of their history, we may check things like blood clotting factors to determine if their blood is clotting normally, meaning if you get a cut on your arm and all of the mechanisms to stop bleeding should cause you to form a clot and then ultimately a scab. If your bleeding time and different other lab tests are off, that could be why your periods are really heavy. If you're on certain medications, I've had patients who had otherwise been healthy previously, and they're now on a blood thinner because they got a blood clot in their leg, and now their periods are super heavy. Well, that's because they're taking a medication that affects their body's ability to clot. And so now they may be having heavy bleeding, and it may be temporary because maybe they don't have to be on the blood thinner for so long. But those are things that are completely reasonable. And, heavy bleeding is kind of a bread and butter gynecologic complaint. And so, blood work, ultrasound are pretty standard. So it shouldn't be something that a patient should be having, a hard time. They shouldn't be begging their doctor to get that. You know what I mean? And I'm sure that has absolutely happened. I'm sure patients have gone in with concerns and said, hey, well, do you think an ultrasound would be helpful? And they've been brushed off. But for something like heavy bleeding, chronic pelvic pain, or chronic pain with periods specifically, those are absolutely things that warrant ultrasound and possibly other evaluations.
Yeah, I definitely have been brushed off about an ultrasound before. Oh, it's not necessary. Oh, whatever. So that's why I asked, because I wish that I had advocated for myself some more. So we have another question. Is it typical to bleed heavily beyond the first 1 to 3 days of a 7-day period, so heavy that the likelihood of an accident, especially when sleeping, occurs?
No, I would say that warrants a workup. I mean, some women do bleed heavily the entire time. Some women just bleed heavily in the beginning. I have some women who just spot in the beginning and then bleed heavily mid-cycle. So if it's that heavy and they're bleeding through pads and or tampons or Diva cups or whatever they're using, I say that warrants a workup. Dr. King, what do you think? I always work that up.
Absolutely. Yeah, I mean, if you're like day 4 or 5 in your cycle and you're concerned you're going to leak overnight, I think that warrants a workup. And it's interesting, you know, like Dr. Javaid said, like there used to be these like numbers, like if someone was bleeding over 80 milliliters a cycle, it's like, what? How are we measuring this?
I never measured that as a doctor. Did you? I mean, how
never. Like, how is that possible? But if that person does come in, we can do a laboratory assessment to see. Now, and like Dr. Javaid said, I think it's awesome that it's transitioned to kind of more patient perception. And with that being said, I'm sure she can attest to, sometimes we have patients come in that will say, oh my gosh, my periods are so heavy, you know, and they'll describe more. And then we do their blood test and their hemoglobin's like 14. And for anybody that's listening that knows what that means, that means they are like stone cold normal, like they couldn't get any more normal. They're actually like high normal. And that also means that their body, despite how much they're bleeding a month, has the reserve and the capacity to keep up with not going to a 9 or 8 or a 7. And so then we have the opportunity to counsel and say, okay, well, let's really talk about when you say you're changing your pads every 2 hours, does that mean you're changing them, or every 1 to 2 hours, if we want to make it a little more dramatic? Are you changing them every 1 to 2 hours because they're like saturated soaked? Or are you changing them simply because it's for a comfort level? You had to go to the bathroom, you looked down, you didn't want to see blood if you're wearing a pad, or you just, you know, you needed to take out your tampon. You know, that's completely different than, oh my God, I have on 2 overnight pads in the daytime. I stood up and I feel like I'm flooding and things are gushing out, and I just changed a pad an hour ago. That's totally different than changing for comfort, which again, sometimes, again, you just have to kind of help people frame expectations about kind of like Dr. Javaid said, what's typical and what's not. But, you know, again, all that comes with education and our ability to, you know, to counsel patients and kind of help empower them with that information.
And Dr. King said, you know, we don't have time for, you know, 100 questions, but I definitely spend a lot of time with my patients. I want them to come to me with their concerns. I want them to be comfortable. But what I do tell them, you know, women already have so many barriers to healthcare, whether it's lack of research funding or the fact that we're not, you know, making decisions about our bodies and we're not in those leadership roles, or that we're underrepresented in 3 out of every 4 major medical studies still in 2020. That should make everyone mad. But we as patients should not be barriers ourselves. And so come prepared. If you're having heavy bleeding, but you also need an annual, let the annual go and talk to your doctor. Pick the biggest issue. Don't worry about the other maintenance stuff, and really address what is happening. If you're having severe pain, same thing, bring that issue up. Dr. King and I, that may be the only thing we can deal with that day, but at least we can get the most important thing done. Write down your questions. If you've been dismissed before and you're nervous in a doctor's setting, write down your questions, do your research, advocate for yourselves. And I completely agree with Dr. King. If your physician does not listen to you or brushes you off, or doesn't even offer you, like sometimes they'll say, okay, we'll deal with this today. I hear you on that. I'm gonna order this so that next time we're ready. Please schedule, you know, in 14 days and we'll go through everything again together. If they don't offer you that and they don't want to be a partner with you in your care, then next doctor, please.
Devin,
yeah.
I'm so curious, Devin, you know, this was not my experience very early on, you know, when I first started seeing OBs and gynecologists. What was your experience in terms of getting help for your heavy periods?
So my journey from diagnosis to the actual surgery took over a year. And so for someone who was bleeding 2 weeks out of the month, it seemed like forever. And again, I think part of it was because I didn't have the resources and I wasn't necessarily looking for them. I think one of the biggest pieces of advice that I have for people is to try not to go to your doctor and diagnose yourself. I can admit my very first doctor's appointment, I went and I was like, oh, I think maybe I have an STD or maybe like I'm pregnant or something. Like, I don't know. I didn't really know what fibroids were. I just my impression of an OBGYN was either you're going because you're pregnant, because you have an STD, or because you're getting your annual. And if it's not one of those three things, then what are you doing there? And that's definitely, something that is, a complete fallacy. And I would consider myself to be someone who's, highly educated, like I should know better. But I think sometimes when we think we know so much and we do these WebMD searches and we're talking to people who are not necessarily the most qualified, we can kind of go in with these ideas of things. And when you have certain, physicians who might be busy and that's what you put on the thing, I think I'm pregnant or I think I have an STD, that's what they're going to be focused on, trying to see, are you pregnant or do you have an STD? But I think, especially for me, once I realized that I had fibroids, I found out through an experience with bleeding where I actually passed out outside of the courthouse that same day. And I ended up getting lab work done and my hemoglobin was at a 6 and I ended up getting a blood transfusion. I got 2 units of blood that same day. And the very first thing that they said to me in the ER was, you need a hysterectomy. And I freaked out. I called my mom. And I think that, from talking to other women, often when you get, doctors who are not Dr. Javaid or Dr. King, sometimes if, they're not up to date on the newest practices, or maybe it's just not something that is, I found sanctioned by their organization. I had one insurance company that really pushed one procedure, and that was just kind of the standard. And so it wasn't even for me as much as doing research on the doctors, but also calling my insurance company and asking, what would they pay for? I probably went to about 6 different doctors before I went to Johns Hopkins here in Baltimore, Maryland. And there was a doctor who performed a robotic myomectomy, which for me as a new attorney, the first thing I heard when they said hysterectomy was 6 to 8 weeks, out of work, maybe even months. And I was like, I don't even have the leave for that. Right. So it's not even just the challenge of, what are the barriers to getting into the front door to get the appointment? But once I get the appointment, how am I going to pay for it? And then once they tell me that I can have the procedure, how am I going to afford myself during that time period where I'm going to be off? Who's going to care for me? I'm a single Black woman living in Baltimore. My family doesn't live here. So now I have to coordinate with people to get them to where I'm at. So it's definitely a lot to think about. And again, I keep telling myself, had I involved my tribe, had I reached out to some of my line sisters, my mentors, people that I'm really close to, and I would call them for anything else, right? Like I'd call them after a breakup, or I'd call them, if there were any other major crisis in my life. I regret that I didn't treat my health the same way. And I thought that was such a taboo subject. I think I would have gotten referrals even sooner. I probably wouldn't have gone to 6 different doctors. It actually turns out after I had gotten my surgery and I, was feeling a lot better, that's when I told people. And one of my sorority sisters actually works with the doctor who did my surgery. And of course she, because of, confidentiality, like she couldn't say anything. And it was just a moment where I was, really reflective and was like, wow, like had I just reached out instead of going to 6, I probably would have only gone to 2.
Yeah. And it's so funny you mentioned that because someone just typed, it's so important for us to have these conversations. After I was diagnosed, my grandmother told me that her mother had fibroids as well. And that's the same situation with me. I had fibroids and then I'm having a surgery and my mom's like, oh yeah, well I have some too. And I'm like, hello.
Same
yeah, I had no idea.
The day of my surgery, my dad's aunt actually called and was like, oh yeah, like I think I had surgery for that. I think I had a hysterectomy. And it was just another moment where I'm like, wow, like you're 70 and you don't know like what you had, you didn't ask, you don't know what they took out or why they took it out. And so again, I just think, you know, having these conversations, it's definitely something that, you know, I will do with my daughter when I have one, my nieces, you know, I think it's just normalizing it and making people feel like it's okay to talk about him, you know, the same way you talk about like, why do I get, you know, this birthmark, this pimple, like it's just, it's so common seeing the statistics.
And you brought something up earlier, you know, men talk about this with absolutely no shame. There are infomercials on TV about erectile dysfunction. And that is on TV for the whole world to see, but yet, you know, we can't talk about, or we don't talk about periods or fibroids or PCOS or endometriosis or anything along that lines, but they've got Viagra commercials, you know, like it's no problem whatsoever. I want to get back to a question in the chat. This one has to do with weight gain. Can weight gain or stubborn weight be due to fibroids? If so, how can you tell? Also, is it normal for breasts to swell and feel very sore leading up to your period?
Yeah, so I would say in terms of the weight gain, women can definitely have a change in their like abdominal girth if they have some pretty significant fibroids. And like we said, an ultrasound or even sometimes a CAT scan or a CT scan or an MRI will be able to tell us how large those fibroids are. Fibroids can be like itty bitty, you know, like the size of your fingernail, or they can be like the size of a baby, like literally. And so really it depends on the size of the fibroid. Fibroids aren't typically going to cause generalized weight gain, meaning you're not going to gain weight and you know, your arms and your legs and your butt are getting bigger just because of fibroids. But if you notice over say months or a year or 2 years, like, you know, everything else is staying kind of the same, but you just feel like your belly is getting larger or distended, or you even start feeling almost, you know, kind of a firm roundness or just a firm shape in your abdomen that wasn't there before, that could absolutely be due to fibroids. Like I've seen some patients who have happened to be, you know, fairly thin, and they'll be like, yeah, I feel something in here, and I press on their abdomen and their uterus is up to their belly button, which in like the OB world, that's considered like a 20-week size uterus, meaning about the size that a baby would be in the womb at 20 weeks. And they're kind of like, I'm not really sure what it is. And, you know, they've had a pregnancy test at this point in the office, and it's like, you, my friend, have fibroids. So they could absolutely cause kind of abdominal distension or an increase in girth in the waistline. What was that second question? It was,
Hold on, let me
I don't have my chat pulled up, sorry.
Nope, you're fine. Oh, is it normal for your breasts to swell and feel very sore leading up to a period?
Oh yeah, a lot of women have breast tenderness, soreness, swelling, etc. before their periods. There are a lot of hormonal fluctuations that are happening throughout the entire, when I say cycle, I don't just mean the 5 to 7 days that you're bleeding, but like Dr. Javed said, from that first day of the first period to the first day of the next period, we consider that like the menstrual cycle. And there are a lot of hormonal fluctuations. Breast tissue is very hormonally responsive. And so sometimes those hormonal fluctuations can cause breast tenderness and swelling, kind of like when women are pregnant. You know, women have breast tissue, like what we call hyperplasia or hypertrophy, meaning the tissue kind of enlarges and engorges and swells in preparation for the baby coming. But obviously just during a regular cycle when you're not pregnant, you have more ebbs and flows of those hormones up and down. So it's not a sustained swelling or tenderness. It usually, you know, happens before the periods, and then either with the period or shortly after, the symptoms will resolve.
And that abdominal girth can be pretty significant. I remember being a resident physician, and a woman walked in and she was convinced she was 9 months pregnant. She was very thin and she looked like she had this giant, you know, baby. And we did an ultrasound. Her pregnancy test was negative, and it was fibroids, and they were much larger than 20-week size. They were 36-week size. And obviously she needed a hysterectomy. But I asked her what took her so long, and she said she was so embarrassed. Like, she didn't like the way she looked. She didn't have any safe space to talk to. And so that was the delay in her care. It wasn't that she was blown off or dismissed by physicians. But, and we touched on some of the treatment options, but, you mentioned myomectomy. So that's removal of just the fibroids, which is very important for young women, right? Like Dr. King and I take care of, that still want to preserve their fertility and keep their uterus. There's obviously hysterectomy. There's a couple different types, vaginal, abdominal, robotic, which is minimally invasive. And there are medications and other things that we can do. Someone mentioned, Listita, which is a medication that we give them to, control bleeding. IUDs, depending on where the fibroid is, because they can grow in a couple different places, right? They can grow within the uterine cavity where babies grow, kind of in the muscular layer, and then kind of hanging off the uterus. Those usually cause the least amount of bleeding issues, but definitely can cause pain or constipation or even problems with urination. For me, really specializing in sexual health, a lot of times when Dr. King said that they feel like something's moving around in there, my patient's first touch will be like, I was having sex and it felt like there was a baby moving in there, but I'm not pregnant. And so we do an ultrasound, and sure enough, there's a large fibroid in there that when things are shifted during intercourse, it moves, or women perceive it when they're working out. So one of the warning signs, though, that I wanted to talk about is if someone knows they have fibroids, but they're not bleeding heavily and they're not bothered by it, but all of a sudden they're rapidly enlarging, and all of a sudden their abdominal girth is changing and their clothes are not fitting. Another key symptom that they need to get on the phone with their gynecologist, and that requires some evaluation to make sure those fibroids, most of the time benign, but can convert into something that is cancerous or not benign, like a leiomyosarcoma, very rare, but that's one of the symptoms that we tell patients, hey, you need to talk to your gynecologist about this.
Yeah. So I do want to piggyback off of that, Dr. Javaid, because we did have a question. A woman said that she had some small fibroids that didn't cause, any issues or quality of life issues at all. And that was a while ago that she got that diagnosis, but now she's had heavier bleeding and lower back pain. Does that indicate that those fibroids have grown?
Absolutely. So a change in symptomatology, not all fibroids need treatment. Definitely we need to keep track. Patients need to keep track. But if there's a change in pain, sex, bleeding, constipation, because uteruses can be tipped forward, that's called anteverted, or tipped on the bladder. They can be retroverted, which means they're tipped towards the rectum or towards our back, and so women feel more back pain or back labor with those. So yeah, if there's any of those symptoms, all of a sudden, change in bleeding, change in pain, problems with constipation, even pain down the leg, sciatic pain, and it wasn't there before, that is definitely a sign that they need a workup and need to be seen by their gynecologist.
If anyone does have anemia or they're bleeding heavily and they've been diagnosed with low iron, is there something that they should be taking to supplement that?
Yeah, so it depends on the level of anemia. So Dr. King, those numbers that she threw out, those are significantly low. And so transfusions, and that depends on a couple different things. Their medical history, how symptomatic they are, their resting vital signs, are they able to, work and go to school and do their functions? So sometimes transfusions, sometimes I really like the slow release irons. I think they're less irritating to the abdominal, symptom or system. Sometimes they need IV iron if they need it quickly, and we don't want to wait for the amount of time for it to go in, because it does take the body a while to recover from that bleeding. And if you think about it, and women are bleeding what we call normally or typically once a month, it takes us a couple of months, like Dr. King referred to recover from that. So if we're emptying our reserves every month, we're not giving our body enough time to recover. So we can do that by supplementing with some iron. But sometimes women need transfusions. Yeah.
Yeah. Okay. So as per usual, I am running out of time. I always talk and talk and talk. So I'm going to get through a couple more questions really quickly. How quickly can benign polyps or cysts grow to be disruptive fibroids, causing abdominal distension and heavy periods?
So I would say a cyst is not going to grow into a fibroid. and cysts are generally on the ovaries. So a cyst can potentially enlarge rapidly. And typically someone would have symptoms of having no pain and then going to either pain, pressure, fullness. But yes, cysts will not transform into a fibroid. A fibroid is specifically part of the smooth muscle tissue within the uterus that just kind of grows super crazy. But fibroids don't necessarily just grow all of a sudden where it's 1 centimeter today and tomorrow it's 10. If that is the case, like Dr. Gervais mentioned, someone may have what's called a leiomyosarcoma, and those are very rapidly enlarging cancerous growths in the uterus. But you know, it really depends. That question's a little hard to answer in terms of how fast it grows, because we don't always necessarily say, if a patient's completely asymptomatic, I would say if you develop symptoms, let's follow up again. Let's get another ultrasound, like Dr. Gervais said. Let's see if there has been growth. If they're coming in acutely with symptoms, and this is their first time ever coming, I may or may not have a baseline. Now, if they've had a baseline ultrasound and say they just happen to get an ultrasound for, I don't know, say they had pelvic pain 2 years ago and they had no fibroids 2 years ago, and now they have 2 fibroids that are 4 centimeters, I wouldn't be too concerned in terms of the amount of growth that took place over 2 years. Do you see what I'm saying? So it's not the most straightforward answer to give, because we're not always tracking the growth, you know, in increments that we're specifically looking at how fast they have grown in the meantime, unless someone is acutely symptomatic or unless we're specifically following the growth.
And to add to that, a polyp is also, if I confused anyone by bringing.
Oh yeah, I forgot to answer the polyp part.
Yeah, so that's a different entity as well. So they can grow in noses. So people who get, you know, nosebleeds, they can have nasal polyps. We hear about them in the colon, you know, colonic polyps. They're definitely in the uterus as well, and they're not cancerous necessarily. They can be benign, or what we call hyperplastic, and there's 4 different types of hyperplasia, and they're treated, you know, simply by sometimes just removing them, and that's not a hysterectomy. That's not even an abdominal surgery. You know, in our office, we do it right in the office with some camera, you know, and just directly removing the polyp. They're usually pretty small, but they're very vascular, meaning they have a lot of blood flow to them, so they can cause a lot of bleeding, but they're typically generally very easy to remove. And if they are hyperplastic, I hate the word precancer, because some hyperplasia, even if left untreated, only has a 3% chance of becoming any type of uterine cancer. But sometimes that's treated with either an IUD or high dose progestins. So it just depends on what the pathology report or what the tissue looks like under a microscope. So polyps are also a different entity. So these are all physical reasons that a woman can present with abnormal bleeding.
Yeah.
Understood. Are there any treatments outside of birth control pills for heavy periods? We had someone ask about organic tampons or organic pads.
So a pad or a tampon isn't going to necessarily treat heavy bleeding. And Dr. Gervais alluded to this a little bit earlier. She talked about some treatments. One thing I really quickly want to say before I answer that is, if you're going to a physician and they say you have fibroids, you have heavy bleeding, and if all they offer you is a hysterectomy, run like the wind. Unless your uterus is, like she mentioned, 36 weeks. Because if your uterus is up to under your rib cage, there's unlikely any other options that are really truly going to work. Like they're just not going to work. Your uterus is way too big. Nothing really is going to effectively work on a uterus that big. If you have, say 3 or 4 fibroids, and they're 3 centimeters or so, I'm just making up some numbers as I go here, but there are lots of other options specifically for fibroids and heavy bleeding. And when I talk to patients, I always walk them through the least invasive to the most invasive. So the least invasive, honestly, is doing nothing. If that patient has fibroids and they have no symptoms, they just happen to have say they had an ultrasound for some other reason, pelvic pain or what have you, and they found they had a 2 centimeter fibroid, but they have no heavy bleeding, their hemoglobin is 12, and they're not concerned about it, there's really nothing we have to do at all. If they are symptomatic, one of the next steps may be doing a birth control. A next step after that may be doing something like an IUD. For some women, there's another medication called Lysteta, which kind of helps to help the blood kind of clot and the woman not be bleeding so heavy. If they have fibroids specifically, if we're going into surgical options, we may be talking about a myomectomy, which is specifically removing the fibroid. Say they don't have fibroids, but they have heavy bleeding, we may be looking at something called an ablation, which is essentially burning or freezing potentially the lining of the uterus so that that lining is kind of destroyed and therefore won't have the potential to bleed really heavy in future months. There are other procedures, uterine artery embolization. That's usually done by interventional radiology, where they basically get a catheter placed in the groin. The catheter then finds the blood supply to the uterus, the uterine arteries, and then the arteries are embolized, meaning they put a special material in them to decrease the blood supply to the uterus. When you do that, you therefore decrease the blood supply to the fibroids and the fibroids shrink. There's something called a CESA, which is a laparoscopic procedure that basically they put a radio frequency probe once they get into your belly, and they use an ultrasound, they find the fibroids, and they insert a probe into the fibroids, and it's activated, and then the fibroids and the proteins in the fibroids are kind of denatured and they basically die. And then after all that, would be a hysterectomy. I cannot tell you the number of times I've had patients in the office say, well, they just told me I had to get a hysterectomy. And the person may be like, I don't know, it doesn't even matter how old they are really, unless they're, their uterus is up under the rib cage. We have to be offering patients options. Now, if a patient comes in and they're like, I have dealt with these fibroids for 10 years, I have tried every single method under the sun, and I just want this thing out. Well, then I still honestly go over all the options so that they feel like they've heard it. If they're just like, I just want a hysterectomy, or I just want this out, or whatever, that's one thing. But never should there only be one option given. And even if that one option is the best choice, they still should kind of just say, these are the other things, but let me tell you why we aren't doing these. I can't do a myomectomy and your entire uterus that's up to your belly is measuring 25, 26 centimeters. I can't do a uterine artery embolization on that. It's not going to be effective. I can't do an accessive procedure on that. It's not going to be effective. You know what I mean? So we have to be making sure that the options are given. And that's why I love these types of platforms, because there might be a woman on here that was told she had to have a hysterectomy, and she might be 35 and still want to have another baby. And she's like, wait, I actually have options. My fibroid is 8 centimeters and maybe I can do something else for this. So.
Mm-hmm. Yeah, and there's also Depo-Lupron that you can give, right?
Oh, yeah, Lupron and Depo.
Drink, and there's a new one called Orion. I haven't prescribed that yet, that the FDA just approved for heavy bleeding. So there are definitely options. And then also ablation. An ablation doesn't remove a fibroid, but if the fibroid, remember, is growing inside the cavity, sometimes we'll remove that fibroid and then ablate behind it. And I will tell you, I shared a similar experience. I was bleeding so heavily as an OBGYN. I actually stood up in an office where I was doing a procedure on a patient and stood up and actually bled through my clothes. It felt like my water broke. And for me, it wasn't not knowing. I knew I needed to get in. It was like, do I have the time to take off? I don't want a hysterectomy for other reasons. And so I had an ablation myself 8 years ago, and it is the best thing that I ever did for myself. Obviously, we have to make sure you're a correct candidate, that you don't have any medical problems that preclude you from getting that your uterus is not too big or too small, or that you don't have very large fibroids in the way, because there's a device that has to open up in the uterus. But that's a nice alternative for a lot of women to a hysterectomy, and the downtime is pretty minimal. I mean, we're doing them in the office, and women will go back to work the next day sometimes, and total surgery time is 2 to 6 minutes, because there's no incisions made in the abdominal cavity. And so I don't think a lot of women will ask for an ablation. Sometimes I'm shocked they come to me for second, third opinion. They're not even offered these lesser invasive procedures, which is always mind-boggling to me, that a lot of doctors just want to jump to, cutting everything out. And I tell women a lot of times, just because I do specialize in sexual function, you may be getting rid of the bleeding and pain, but you may have other issues then that you are inviting into your life. And so let's make sure that we know all risks, benefits, and alternatives, and that you have an informed decision about your body before you do something permanent.
Absolutely. I have a two-part question based on all of the treatment options that you all just gave. The first question is, what options are available besides myomectomy and obviously a hysterectomy to preserve fertility? And also, after a hysteroscopic myomectomy and a CESA, is it normal to bleed for weeks? What does recovery look like after some of these treatments?
Say that
So,
first question. Oh yeah, go ahead, Dr. Gervais.
yeah, no, so I think we brought up some of the treatment options that will preserve fertility. So birth control, obviously, but not while you're on it. You're not going to be fertile, but you'll have no problems in return to fertility. An IUD can be placed in the short term to get you to stop bleeding, to recover. You don't want to become pregnant when you're profoundly anemic. It's not great for you. It's not great for the baby. Listita is also another option. Lupron, which can shrink the fibroids, but it can take up to a year to get pregnant after you receive your last treatment. So, and a myomectomy also as well, you can preserve fertility. So all of those options preserve fertility. Some of those may require that you need a cesarean section with delivery, depending on what happens to your uterus. And as far as bleeding after procedures, I tell people a couple of weeks they can bleed. But once again, if they have fevers, bleeding more than a pad an hour, it's not typical. And if their bleeding is extended for an extended period of time, I'll tell them 2 to 3 weeks. Then I have them come back in that post-op period. We do an exam and we make sure that they don't have an infection. Sometimes an infection, we have a lot of bacteria in our vagina. It's healthy bacteria, but sometimes if it gets into that sterile space in the uterus or in the abdominal cavity, it can cause infection, which can present not always with fever, but with prolonged or abnormal uterine bleeding.
And then last question, because we are running out of time and I want to get back to Devin, but last question for the doctors. What do you advise patients who have fibroids with heavy bleeding and are trying to conceive, but are debating how long to wait to determine if surgery is the best option? And I have friends who have been through this. They know they have fibroids. They've been told, you know, these fibroids will not interfere with your pregnancy, but you know, you could have surgery, you could get pregnant. How do you kind of weigh those options?
I think there's a lot to consider there. You know, if they've successfully gotten pregnant before in the presence of fibroids, that's a good indicator that, you know, they can get pregnant again despite the fibroids being there, versus say a patient who's never been pregnant, who doesn't really know if they have the potential to get pregnant. Because then we're wondering, well, have you been trying for a year or two or however long you've been trying and you haven't been able to get pregnant because a fibroid is in the cavity and is blocking one of your fallopian tubes. And so I think we have to have a little bit more information in terms of being able to determine if someone specifically needs surgery. Now, if they are severely anemic, if they have significant pain, and this is just ongoing, it may behoove them to treat the fibroids so that they can just not be bleeding every month so heavily or having so much pain. Or like Dr. Gervais said, if you're walking around with a hemoglobin of 6 and you get pregnant, that's not good. And so it may behoove them to alleviate their symptoms, allow their body to heal for a couple of months, and then, you know, go forth with attempting to conceive. If it's an actual issue of infertility that maybe they've either seen an REI or reproductive endocrinologist and infertility specialist, and for whatever reason, if they've tried for a year and they haven't been successful, and they also have known fibroids, they may say, you know what, you have these heavy periods, you've been trying for a year, let's kill 2 birds with 1 stone and get these fibroids out. So I think honestly, a lot of it comes down to talking to the patient, talking about their desires. If they say, you know what, I know I want to have a baby, but I'm really not looking out until a year or 2, but I just want to make sure everything's good, I wouldn't necessarily advise that person to go on bleeding heavily for 2 years. Do you know what I mean? And so a lot of the care and a lot of the counseling will be tailored based on exactly how the patient is presenting in the physician's office.
And the quality of life.
Or should be tailored, hopefully. I mean, medicine is not, some things are kind of, you know, we're going to do the same thing for every patient, but medicine is not one size fits all.
Absolutely. Okay, last medical question. Then Devin, I want you to share your experience with recovery. Last question for the doctors. One more, please. Is it normal to expel a fibroid through the vagina like a blood clot?
There's that normal word again, right? So that is not very common. It does happen. If there is a fibroid, Dr. Gervais mentioned, I always tell patients, I'm a super visual person, so I always tell patients, your uterus looks like a balloon blown up, and then the part that you blow up is like your cervix. So if you have intracavitary fibroids, meaning inside the cavity of the uterus, and they're kind of like hanging down, they can outgrow their blood supply sometimes. And when that happens, they can basically necrose or kind of fall off of their stalk and die. And they have to try and get out. Like, your body is like, we don't want this just hanging out in here. So a lot of women will describe very intense, almost like labor pains, or as if they're having a miscarriage. They may have some heavy bleeding, and they can expel a fibroid. I wouldn't say that that's like just a typical experience that people with fibroids are going to go running around having fibroids fall out of their vagina, but it's definitely something that can happen.
No, and I've seen it, and it almost looks like a baby's head coming out, and it was very, very painful for the patient. She actually ended up in the ER, and we had to, help extract the fibroid, and it looked like a baby's head coming down. And she had the heaviest bleeding of her life. There was one other thing I wanted to mention when you were talking about intervening for patients. I think, you and I take care of different patient populations as far as age. You take care of a lot younger patients than I do. But I think, a 40-year-old woman who's coming to me for infertility and fibroids versus a 25-year-old, and I hate blaming things on age, but we do have a certain amount of time that we are fertile. Right after menopause, we're not fertile anymore. And so I'm a lot more aggressive. I have to be, because there's less time that I have to help that patient. And so I know you brought up that 12 months because that's what ACOG says, right? 12 months of unprotected intercourse. And if they haven't gotten pregnant, then we need to intervene. But I know, you'll agree that older patients, sometimes we do intervene a little bit more.
For sure.
Yes. Yeah.
Yeah, I know my experience.
That's why I said it really is tailored to each patient. And some of the questions are a little hard to answer, because literally each patient, even though they may all come in with heavy bleeding and fibroids, like you said, if you have a 40-year-old and I'm talking to a 20-year-old with a fibroid, it could just be a completely different. And honestly, the 40-year-old might have a 2-centimeter fibroid that I say, don't worry about it. And the 20-year-old might have an 8-centimeter fibroid, and she's bleeding like stink every month. So, every physician has to take into account every single detail of each patient that is presented to them.
Yeah, I say with my experience, I went to one doctor and she saw the fibroid immediately. She was like, your uterus is enlarged, go get this ultrasound. We need to figure out what's happening, because it wasn't here a year ago. But, she looked at my ultrasound. She said, well, if it doesn't affect your quality of life, then we can just, sit and wait. I went to a fertility doctor that next week, and she was like, wait for what? We're going to take it out. I'm going to recommend you to another surgeon, and we're going to get it out. You're young. You want to have kids. You're about to be married. What are we waiting for? What are we watching this for? So Devin, I want to get to you. I want you to jump in here. You had the myomectomy, and you said it was laparoscopic. So talk about your recovery.
Yes. So honestly, I had the procedure June 9th of this year. It was the best day of my life. There is nothing that compares to the pain of having the fibroids, the pressure, the bleeding. And so comparatively, the surgery, the worst part was just being nervous about well, what happens when I'm under anesthesia? What if I wake up? Will I wake up? Like those types of questions. I certainly don't want to glamorize it. It's not like I skipped out of the hospital, like, woohoo, I'm a brand new woman. There was definitely pain, but I think my doctors did a really great job of helping me to manage that pain. So I left, the day of my surgery with all the prescriptions that I needed. I, at that point, was able to kind of open up a little bit more and talk to other women. So I had the heating pads ready. I had, my comfy pillow on the couch. I had, all the foods that I wanted to eat. I had a little grabber because for the longest time I wasn't able to bend over and kind of reach things. So I did have some mobility issues. But again, the cramps that I had, the pain, it was nothing compared to the fibroids. And now I'm so happy. I've had, periods since then. They've been 4 days instead of 2 weeks. The bleeding is finally normal. I'm not, getting the size 5 maxi pads and, layering them up and getting the, tampons as a backup. I can just kind of live my life. I can literally wear white again. I'm not, planning my outfits around my cycles. I'm also, a single woman. And so in terms of dating, right, like that sucked, meeting guys and being like, so, actually, I've got this little issue, right? Like there's none of that. And of course, it's nothing to be ashamed of. I think ideally we would all want a partner that we can talk about those issues with. But sometimes as a first date question, second date question, right? Like you just don't want to explain why you keep having to run to the restroom, or why like Netflix and chill and sleepovers are just not a thing during certain times of the month. So I again, I don't want to glamorize the recovery because it was certainly a struggle, but I'm glad to be at the, end of the tunnel. And of course I worry, like many other women who've had the procedure, will my fibroids come back? What can I do? But I think, the biggest learning lesson that I took from it is to, now continue to talk to other women, continue to talk to my, my doctor. And he's like, well, if you want to come in for an ultrasound, sure, come in, do what you need to do. There's a lot of literature online, and I think maybe the doctors can speak to this, but I think there are a lot of people who talk about healthy eating, and I can't necessarily say whether one type of food triggers fibroids or not, because I think that there's just so much more research that needs to be done. But I'm definitely more cognizant of what I'm putting in my body, and the way I perceive it is, even if it's not helping my fibroids, it's still helping me overall in terms of my health. So it's a win-win.
Absolutely. So I do need to start wrapping up. So Dr. Javaid and Dr. King, are there any last final thoughts that you want to share with the people who've joined tonight?
I want to thank everyone for tuning in. I think, education is so important to both Dr. King and I, so that we don't continue these negative experiences that everyone had. And we teach young girls and each other about what our bodies should and should not do. And we should eliminate any shame that comes along with what is very typical: menstruation and infertility and sex. We all mentioned Viagra and ED and how easy it is for men, to talk about, and we really need to narrow that gender gap. I think the one thing we also need to talk about are some of the products. We talked about tampons, we talked about pads. There are a couple of, and Dr. King, I'd love for you to jump in too, but there's menstrual underwear now, there's menstrual shorts, there are, Diva cups. So there's a lot of things that can help women manage their bleeding so they don't have to have, those embarrassing accidents, especially when they're, waiting for the workup or waiting to get into their physician. There's ways to definitely help manage the bleeding. And I'm a big proponent of, the menstrual underwear. I actually got to take a trip out to Tanzania and take it to some girls, because definitely, we all know there's period poverty in this country. But in Tanzania, where I went with my daughters, 1 out of every 10 girls actually drops out of school because they don't have access to pads and tampons. And think about that. If you're bleeding 7 days a month and you're missing out, their school is 10 months, you're talking about, 70 days of school. And so you end up staying home. And so I think that's another thing that we need to talk about. So I always tell my patients who've had a hysterectomy or had a myomectomy or had an ablation, and you don't need as many pads or tampons, donate them to a women's shelter, get involved and send them to an organization that will get them to girls who are in desperate need of things that sometimes we take for granted as women.
Yeah.
And those are my last thoughts. Yeah.
And I would totally agree. I actually recently partnered with Always, and the problem may not be as big here, but they did their own study for their brand, and about 1 in 5 girls here in the United States, not in a developing country, 1 in 5 girls here missed school due to lack of period products. And then there were about 1 in 4 girls, so 25% of girls were even worried during the whole quarantine, coronavirus experience, that they would have continuing lack of access during this period because maybe their parents have lost their jobs, you know, and money is tight and money has to go to a bill versus, you know, a period product. So I actually just recently kind of stocked up on a bunch of products so I could donate them as well. So, you know, it's interesting because we all have various, you know, issues in life that we have to overcome. And there's always people that have issues that seem worse, you know, that I think that if we keep sharing these stories, some people, when I shared that, they were like, here in the United States, this is happening. And I'm like, here in the United States, this is happening. So this is literally a global issue that I think, as we've discussed through this whole thing, if we can keep educating women, empowering women with this information, they can know what's normal, typical, versus what is not normal or not expected. And we can help them kind of thrive and optimize their health versus living in shame. In some instances, I know not every woman is walking around living in shame, but too many of us are, you know, and I think the more we share stories, the more we have these conversations, the less likely a woman will have to live in that experience.
Absolutely. Okay, so I'm going to ask Dr. King, Dr. Javed, and Devin, if you all could go to the chat and drop your social media handles for everyone to follow you, any resources that you might have, Dr. King, your website, that would be great. And I also want to let everybody know that we are doing the Dialogue with Doctors again tomorrow night, 8 p.m., as well as Thursday at 8 p.m. And here is the full screen for this. If you guys just want to take a look here and see about registering. The first one tomorrow night, or the second one rather tomorrow night, is what are my treatment options? What do I do next? And then on Thursday, confessions of a fibroid sufferer, the hidden symptoms. So again, really great topics here. It's always my pleasure to be part of this and share the platform and discuss these things out in the open without judgment, without shame. And I'm going to turn it over to Tanika Gray-Valbrun right now. She is the founder of the White Dress Project. We Can Wear White. The whole point of it is we can wear white. We don't have to be ashamed of our periods that might be due to our fibroids. So Tanika, take it away.
Absolutely. Thank you so much, Adrianna. I have had such a wonderful evening tonight, just hearing the stories of women, hearing from the doctors, Dr. Javed and Dr. King. We cannot thank you enough. You are exactly the type of doctors that women need to hear from and feel encouraged that they can find a doctor like you. Devin, you said something about hiding in the crevices when you were initially sharing your story. And at the end, you talked about now you understand why you need to be an advocate for so many women. And I thought that was so powerful. Dr. King, you said, you know, women, well, actually, this was Dr. Javed. Dr. Javed, you said women already have so many barriers when it comes on to managing our health care. We as patients should not serve as barriers ourselves. Go to the doctor prepared, write down your questions, advocate for yourself. I just love it when Dr. King said, you have the capacity to advocate for yourself. If you're going to see someone and your doctor is not receptive to answering your questions, it's time to find a new doctor. And if you go to the doctor and they only offer a hysterectomy, run. So I just love hearing these types of things because this is what we do at the White Dress Project. We encourage women to be their own best health advocate. I loved all the questions tonight. You could have been anywhere else. It's a school night, it's a work night, but putting your health first is so important. And as long as we have a platform, we will continue to do this. We will continue to bring doctors like Dr. Javed, like Dr. King, so that you have access to them. Adrianna, you always answer the call when we call, and you always so freely share your story. So thank you so much for being a part of our community. Nikki on all of our production elements, thank you so much, at Nikki Mayo News, and everyone that put this together. One of our board members is on tonight, and Kim, and she is the one who has connected with all of the doctors sent out all the emails. So I just want to give a big shout out to Nkem because this is a big project for her. And I just love that we're all here and doing everything that we can for our health. Join us tomorrow. One point that I want to finalize on is, I think Augustina in the comments said something about mental health and touching on that as a topic. And we have done that in the past. So we can put the link in our chat for you because I want to make sure you get that, because we definitely recognize that that is an important topic. Fibroids and reproductive health issues as it relates to mental health is very important. Someone else also asked about donating. You can definitely donate. The link is in our bio, and we have a text to give platform, so it's super easy. So that we'll also put that in the chat, and then join us tomorrow for additional commentary and ways to learn more about how to be your own best health advocate. Thank you everyone so much for joining, and see you tomorrow.
Thank you.
Thank you.
Bye.
Bye. Thank you.